Thank you very much for the opportunity to talk. I'm a kidney guy and I'm using a kidney example, but using that purely to illustrate the importance of embedding research into kidney practice. The photo at the front is intentionally pitched because it's taken from CPC, and I'd like to sort of underline the strengths of the bonds between the research institutes around RPA that feed into much of the research. So that's one important embedding step, and Warwick's looking at me here from Centenary, not just CPC. Randomised controls are what we have a great opportunity to do more of in hospitals. We understand we've got a hierarchy of evidence ranging from laboratory stuff that moves through watching what happens in the odd patient to looking at cohorts of patients going through an experience, and then to actually randomise people to a treatment versus another treatment where we've got clinical equipoise to figure out which approach is best. And that's what I'm trying to get across, how we can do more of these in clinical practice in a hospital setting, but how we can think about them a little differently to make them easier, cheaper, and more sustainable. I'm a good guy to talk about this because coming from a kidney background, we're hopeless at doing trials. These are cumulative, this is a graph of cumulative number of published RCTs in medicine. Kidneys bottom out, it's a disaster. So we've got something to achieve. Other reason we've got things to achieve is there are lots of things we do in nephrology that impact patients significantly, that cost an awful lot of money, that don't have an evidence base. And when we go to create an evidence base, we often find that we had the wrong message to start with. This is the example of the erythropoietins. They're not just famous because of Lance Armstrong, but we saw these as one of the greatest breakthroughs in people with kidney failure. Your kidneys produce a hormone called erythropoietin, which talks to your bone marrow and tells it how much blood to produce. Bad kidneys, anemia, no energy, and it makes up many of the symptoms we see. So when these recombinant proteins became available, two things happened. Number one, we saw them as the great advance in kidney disease, and they are an advance. But secondly, they saw them as an enormous revenue stream for pharma. $100 million per year industry in Australia, which was 1/1000th of the global industry. And we took them up because there are a heap of small trials that suggested benefits. But ultimately, 20 years later on, when we finally coerced people into doing large randomised controlled trials, we found that the pharma's recommendation to use these drugs to get a normal haemoglobin actually generated an excess of mortality. People were dying from vascular events. We're better off using half as much of the drug, getting people's haemoglobin up just to a comfortable level, and they get better quality of life and don't die more frequently. Should have done the RCTs first. So, what are the problems with RCTs at the moment? Often they're small, because small's easy to manage, small's easy to get the numbers on board, but small usually doesn't answer the question. Classically, our trials are created by an investigator without consulting the public, picks their favourite treatment, which is not necessarily the best, and compares it to a new one. So you're not comparing best with what might be the best. Our trials often are run short term, but in kidney disease, most of the long-term outcomes happen 5 and 10 years later. So doing a trial that runs for 6 months or 12 months really only gives you surrogate endpoints and often doesn't tell you the truth. Trials in nephrology, like trials everywhere else, are characterised by looking at outcomes that don't really matter to patients. They matter to us, where we like measuring drug levels and numbers in blood, but do they affect whether people live or die or enjoy a good quality of life? Oftentimes those things aren't captured, and when we do them poorly. Our trials are often expensive. Some of the trials we run cost $40,000 per patient, and in a 200 patient trial or a 1,000 patient trial, that's a prohibitive amount of money. In addition, those sort of trials tend to focus just on the trial staff, and the trial staff are often a tiny proportion of your workforce. So the rest of the workforce are toddling along doing usual practice, either ignorant of trials or sometimes resentful because these people doing these trials get to jump on an aeroplane and fly to Paris for an investigator meeting, go to dinners and all that sort of thing. Without involving the full crew, it's very hard to get traction with the trials, and even harder to get the results of those trials embedded back into clinical practice. So what can we do? Firstly, look at our trial design. Keep things simple and they work much better. Assess outcomes that are important to patients as well as clinicians. Do pragmatic study designs. Try and work the study design into what patients go through in the order of their ordinary care. They shouldn't have to do extra visits, minimise extra tests, minimise inconvenience, and that way you can get engagement. Make trials a little bit flexible. Not every unit around the world does things the same way. We need a little bit of flexibility inherent in our designs. Think about cultural change. I think that as a whole, when you talk to people in hospitals, they say, yeah, RCTs are great. They tell us what's best. So we've got that belief, but we've got a lack of infrastructure, qualified staff, funding, and often willing participants to drive enough RCTs. So we need to overcome those major barriers to get things up and running. Got to train our workforce and got to engage our workforce. Got to collaborate more and get everybody on board. So what I'd like to tell you about are very briefly, three trials that this crew are doing. These are my transplant team upstairs. I'm also going to talk about what the dialysis team are doing. As you'll see, there's only one doc in the midst of this, 5 nurses and 3 specific clinical trial staff. And this is the sort of grouping together you need, plus one important missing person who's pictured in the painting, and that is the patient. This is a portrait of a guy who got a transplant some years ago and participated in a clinical trial. So you need everybody on board. So first I'd like to show you an example of a trial of patients on the kidney transplant waiting list. Anybody know anyone who's on the kidney transplant waiting list? You wait a fair old time. Whilst you're on the waiting list, you're inherently on dialysis. Dialysis is pretty tough. We always worried that people on dialysis got a lot more heart disease than anybody else. Therefore, every year we'd review people and put them through a stress test. People always complain. It costs money to see a cardiologist. It's a day off work if you're working. It's not a fun test. Oftentimes they're suboptimal, so you then have to go and have a nuclear test. And if it's positive, you end up having a coronary angiogram and it bumps off what left of your kidneys you've got to start with. All very expensive. And when we've looked at it critically, those tests are only moderately good. A lot of the heart attacks we see after transplant happen in people who had a normal test. And oftentimes when we get an abnormal test, the coronary angiogram's normal and we've wasted everybody's time. So we constructed the Cask trial, which looks at randomising people to either the usual tests or none of the usual tests once you're on the waiting list. We're lucky enough to get NH&MRC funding in addition to Canadian healthcare funding as well. So about $3 million, which is not that much moolah in the scheme of trials, particularly when we're trying to recruit 3,000 patients to it. But nonetheless, we got funding, and the reason the healthcare funders wanted us to be funded for this is they said, wow, you're actually doing less to patients and spending less of our money. We love this trial. We want more of this trial. And the people who were most vocal about that were the patients. So this is currently underway. And to do it, we've used our usual clinical staff. We haven't employed any extra clinical trial staff because we can't afford it. One of my PhD students designed the big database management tool and the case report forms that we use to capture trials information using the RedCat software available through RPA. We serve as the hub of a big spoke that extends internationally via the internet throughout Canada, to Europe, throughout Asia, all the way back to RPA in Sydney where we house all the data and analyse it there. And the people who actually do the work for the trial are our nurses. We have a nurse who's in charge of our waiting list. She said, great, I'd like to know more about my patients. I'd like to expose them to less tests. How about I just work this into my day job? And that's how it's gone. So for almost $0, we've been able to, so far, recruit 509 patients. That slide's a couple of months old. It's now 620 patients, about 3,000, and we're away. And you know what? Everyone's interested in what's happening with Cask. So that's before transplant. We get a great opportunity to capture people for clinical trials when they turn up for transplant. When you turn up for a transplant, your prayers are answered. You'll do anything. You're happy. You want to do what's ever sensible. So it's traditionally been the easiest time to capture people for participation in clinical trials. Now, for years and years, kidney specialists have been paranoid about giving people fluids that has any potassium in it. We've loved this stuff called normal saline. Around the time of a kidney transplant, we typically give Carina, what do you reckon, about 8 to 10 litres of normal saline in the first 24 hours. Carina was one of our star transplant nurses in a previous life. And we overload them with chloride, it turns out. Now, when you do that to a mouse, you often cause kidney failure and hyperkalemia anyway. So we've had this traditional practice that isn't evidence-based And over the last few years, we've been thinking, well, maybe we should give a more balanced thing, something that looks more like blood. None of the pharma industries wanted to do this sort of trial. Because there's no money in it, bag of saline costs $20, the balanced solution costs $40. No one's making money out of that. But it's costing us a lot of money because we believe, because for every kidney transplant we do, 1/3 of them don't work straight away. The kidney stays turned off, possibly due to the influence of these fluids, and people have to stay in hospital for significantly longer periods of time, get dialysis, and get exposed to other complications. So here we're doing a randomised trial of normal saline versus this new fluid, and it's been completely sponsored by the MRFF fund. We heard that the other day at the research symposium. It's a fantastic Commonwealth investment that generates a stream of continual research funding going forward. And the Minister picked our trial to fund this one just because he figured that it could have a very valuable outcome for patients. It was never going to be funded by pharma. And thirdly, because we could do it within usual business. The budget here is lousy, $1 million. We need to study 800 people. That's not enough to even dream of a conventional clinical trial. What we've done here, though, is every person with kidney failure in Australia is registered into a registry called the ANZ Data Registry. All of their details are already embedded. So when they come for transplant, we've embedded within that a randomisation module. And in fact, we don't do it, the nurses don't do it, but the registrar who sees the patient when they come in for transplant says, wow, would you like to go in this trial? Everyone says, sure, because the risks and benefits are largely in favour of going into the trial. And within 3 minutes, they've randomised the patient and entered all of their baseline data simply through the registry. And because of that, two things have happened. Number one, our registrars are really engaged in the trial, as are the nurses, because the nurses administer all of the fluids and they love the best fluids box. It's pretty cool. But our registrars are all amped about it. They're all learning about both our registry and about fluids and how important clinical trials are. And as a consequence, this is one of the rare clinical trials that's recruiting way ahead of schedule. We started in February 18, aiming for 800. The purple cumulative lines are where we're at, and as you can see, the dotted projection line has been exceeded at all time points after the first 4 months by the actual recruitment rate. We're ahead of schedule. This happens in less than 1 out of 10 trials. Why? Because the team are engaged. Nothing to do with the budget. This is the lousiest budget I've ever used, but it's all because we've engaged people and entrenched it, embedded it within routine practice. I'll just finish up with one quick trial on dialysis. You know what one of the major bugbears of people on dialysis is? When your kidneys have failed, you get itchy. You get retention of some salts we know, some salts we don't understand, and a lot of people get driven nuts by the itch of it. We often give people opiates, which make them sedated. They're on dialysis as well, washed out, and at high risk of fall. So it's a lousy outcome. A new non-sedating opioid receptor agonist has been invented. The company wants to make a lot of money out of it and are prepared to spend money on a very large randomised controlled trial. So the design here is very different. 350 people from all over the world, only 5 people at each centre. And this trial pays RPA about $35,000 to do. But again, we've embedded it into clinical practice because who knows best about patient symptoms? Their nurses. Dialysis nurses know all about their patients much better than I do, much better than a clinical trials person that you bring in does. So in this trial, what we do is ask our dialysis nurses to ask the patients to score their itch every time they come in using a very simple tool like this. And you know what dialysis nurses do anyhow? They ask their patients how they're going each time. So this is routine business, yet from a hospital perspective, we're generating quite a lot of income to do this work. All of the primary and secondary outcomes are patient-reported outcomes that really matter to patients. So we're delighted to have a drug that can affect those outcomes. Won't do anything to survival, we don't believe, but it'll do a lot to quality of life, and that probably matters most to a lot of people on dialysis. So I think I'll wind up there by just highlighting 3 examples of how we can embed genuine, important clinical trials into everyday practice, and in doing so, recruit our entire workforce, educate them about the importance of clinical trials, but also show them that it's fun, it's great to be engaged and involved, and that they can all make a difference. We would also hypothesise, and we saw some evidence for this yesterday, that if you're actually a trialist, you're more likely to be aware of other trials going along, more likely to take their findings directly into your practice to the betterment of your patients. So what I'd encourage you guys to do here is to think about how to get teamwork going in trials. I'd like to thank the people that contributed to this work, and particularly Tracy Ng, who built the REDCaps database. And think about how you can embed clinical research into your everyday practice with no extra work and not much extra money. Thanks very much.